who's the head of the health system strengthening cluster at the WHO. We have Marc-Alain Widdowson, who's the deputy director of CDC. We have Neren Rao, who's the director for external affairs, policy and communications as MSD out of South Africa. And last but not least, and I'll tell you why this is important, we have Toyin Saraki, who's the founder of the Wellbeing Foundation in Nigeria. So let's give them a quick hand as they're coming on board. Now, Carol Mutoko, in her opening discussions yesterday, told us what this conference is, right? This is the AHA IC conference. And so I've seen people who've been looking intently at their screens as Arif was talking. I saw a cluster there, I saw a cluster there. There's some who are still looking down at their screens, and another cluster at the back. Be warned, I am very good at cold calling because my assumption is you're taking intense notes or you're Googling for data, that you have a really sharp question you want to ask this panel. So be careful. I am that guy who will point you out and ask you what your question is. So please be Googling or at the very worst tweeting about this conference rather than assuming that you can look on Facebook. Are we good? All right, we have 45 minutes for a fantastic discussion. You will notice we have, how many people are familiar with the concept of a manel? Just put your hand up. Very few. So a manel is a panel full of men. So there's a lot of manspreading and mansplaining happening. I'm so grateful for you from rescuing me from this being a manel. So thank you. Thank you very much. But please be warned, for all the other folks, I will particularly give her more time than the men because there's less of her. But also in terms of asking questions, I will likely give a bias to women to ask the questions. So we at least have a bit of a balanced conversation. Are we okay with those ground rules? Fantastic. So I'll ask the panel from that end coming back this way. What are the initial thoughts, comments, reactions to what Arif's opening brief on the SDGs, the challenges and the opportunities going forward? So I'll ask from that side, coming this way, and then we'll try and move this so I can see people over here.
Well, I like the theme that Arif picked on in terms of the private sector's role in these partnerships. That's coming from a private sector company. That's obviously critically important to us. The private sector, in my time within that sector, has shown to be continually looking for opportunities to get involved in partnerships. And those partnerships that we're committed to are the ones that are going to make a meaningful difference. In many cases, or in some, rather I should say in some cases, companies go it their own. They find a program that they want to pursue, but they do it on their own. For me, that's less than ideal. I do believe that our contribution to partnerships could be greater, more fruitful, more meaningful in the long run if we're working together with NGOs, with global institutions, and most importantly, with governments. So why do private sector companies want to be involved in such partnerships? Firstly, I think it bears reminding that we all view ourselves within a broader corporate citizenship role, so that is a primary inspiration to be involved in such partnerships. And I think it's important for the other partners to know and acknowledge our motivations. Secondly, in some countries, in some regions in which we operate, there's a regulatory requirement that we contribute to the local environment. Thirdly, companies need to be committed to the environments in which they operate, and this is something Arif also mentioned. And this goes back, I was an academic many years ago, to a theory that has stood the test of time as other management theories came and went, and that is systems theory. If you want to be part of the system, if you want to operate within the system, you have to contribute to the growth of that system. And companies are critical contributors to the growth, development, and transformation of systems, if one looks at a country as a system. So the world expects us to contribute to the environments in which we operate. The countries in which we operate expect us to contribute. We have good examples of where private sector companies contribute. The PSP-HP partnership in Kenya is one. It's off to a great start, but I have even greater expectations for that partnership. And Arif mentioned that there's a meeting later this week in terms of next steps as far as that partnership's contribution to the SDGs go. So as we progress, I'd also like to get into what makes companies reticent. If we want to contribute, if we want to be active, Why do we sometimes hold back? It's not always to do with budgets, because budgets can be worked around in many instances. What are the other factors? But I don't want to hog the opening remarks. Let's delve into that as we progress.
I'll come back to you on that, because I think that's a critical one if we're going to crack this nut. Dr. Delano.
Thank you very much. As a lifelong civil servant, I'll probably be less about the private sector than my previous colleague has been. I just want to reflect on a couple of things that struck me during the keynote. One is about the wide range of stakeholders that we need to mobilize from the private sector, NGOs, and so on, in order to pursue the SDGs, but critically, again, to look back into our communities as a deep source of resources that would help us get there. And we need to find the means of marrying that to the private sector, to companies, to NGOs and CSOs in a way that produces the best results possible. The second issue that I would like to raise concerns the issue of resources from different sectors and how investment into health and into the SDGs is going to take us forward. And to remember that, excuse me, that there are certain hidden resources. For example, the issue of commodity prices, the issue of the fact that countries don't get the amount of income they should for the oil that is extracted, the diamond that is taken, the gold that is taken away, and how we can mobilize ourselves towards ensuring that our wealth is retained in order to support our development. Thank you.
And that's such a critical question. I think we've seen a lot of commentary and reports coming out around transfer pricing and how that's a major issue, illicit flow of funds, going outside the continent that actually dwarf the kind of typical aid that comes into the continent, and so on and so forth. So that's a fantastic point. Toyin?
Well, I'm looking at it from the point of view of Agenda 2063. We had Agenda 2063, and we had the Common African Position. And there's a lot of convergence between those two, but we're also seeing actually that global funding is beginning to withdraw. So we're having to look internally, in country, to harness the skills that are in country, to look at philanthropy, because we know we are facing a disaster in our primary healthcare system.
Yeah.
A functioning primary healthcare system can actually take care of about 70 to 80% of the needs of our people. But we have, I think, 20.
Yeah.
So we're operating an inverted pyramid, and now the NGOs and CSOs like me are now looking at the health budget and saying, okay, we had the Abuja Declaration. We know about the Alma-Ata Declaration of 1978. You save your people and you actually keep them well at a primary healthcare focus. So we are focusing our efforts for the next 5-10 years on strengthening and revitalizing primary healthcare as the best investment to show this development dividend to keep our people alive.
Yeah. And I think all evidence suggests that it's going to be a difficult time for external funding, particularly funding that comes to the health sector that's not domestic. So if you look at the global gag rule and what that's doing to, from US funding coming to some of these places on the continent, how is that playing out? I will come to you, actually, because you might have a view on that. But also you're seeing a lot of the international foundations that are international in focus, particularly out of the US and Europe, increasingly being domestic. And so their spend is increasingly on domestic issues, leaving much, much less for international questions. I'll skip you, Arif, because I don't want to put you in a strange place where you respond to your own comments. Might be a bit of a circular question, but Alain?
Yeah, no, thank you. We had a conversation about this actually just where we were sitting waiting about the potential drop in funding that might happen with political changes around the world, and how other organizations may or may not pick up that slack. And the gag rule, there's $600 million that the US previously used to give for family planning efforts globally, and I think about $200 million of that's been committed by other partners, but that remains a $400 million gap. My other comments related to Arif's keynote into the SDGs is really, I come from a background of I come from CDC, I think that's clear. At CDC, the way it's organized is actually very stovepiped. We have centers that do different things. We have infectious diseases, we have chronic diseases. Within infectious diseases, we have the kind of sexually transmitted diseases, we have the hepatitis diseases, et cetera, et cetera, et cetera. So what happens, we have, as in all your organizations, we have highly motivated people and they do their thing. The problem with that, and that's why the SDGs are so important, is that we forget about the bigger picture at times. We want to achieve. And I think for me at least, SDGs is a kind of thing that I need to remind myself that, okay, is what I'm doing really important? Is it going to meet this higher goal that's been set? Can I collaborate better? You know, there is an old African saying, you know, if you want to go fast, go alone. If you want to go far, go together. And I have to remind myself that, because it's easy to get enthused about a project or a program and forget that there are others that you can work with to reach not only your goals, but to broaden your goals. And that I think we'll come back to when I have one of my specific questions about HIV and chronic diseases.
Fantastic. Anybody with a question that would like to pose now? Quickly put your hand up and, yep, there's a lady there. We'll just do one question. We'll come back.
Thank you to the panelists for your presentations. So my name is Dr. Maggie Mwaka. My first question is, you've talked about demographic dividends and stakeholders. So how will you ensure that you engage with the African youth, which is 65% of Africa, in order to be able to implement the SDGs, and not only to invest in them, but to invest with them throughout the entire process? Because in order for them to work, you need 65% of Africa backing you up. So that's the first question. Then the second question was, there's a lot of talk about the public-private partnerships, but I feel that anytime I hear these conversations, it's always from the private sector perspective, but we never get to hear the public sector perspective. And then looking at the African perspective, where we're dealing with corruption as one of our biggest monsters, so our health financing is already in a broken state.
Yeah.
And then we have private organizations coming in to fund us. So how do we make sure we hold these parties accountable to make sure that the resources prioritization and utilization is effective?
So I'll establish one ground rule. If you get a chance to ask only one question, so ask the most important question and keep it short. Otherwise, we will not be able to get through. So I'll take off your second question on PPPs off the table, because actually that belongs to the previous session. And I think, you know, Dr. Rago, if he's still here, you should grab him, ask him that particular question. But I'll actually take the first question and twist it a little bit and come to you, Arif, on how do you actually think about practically forging partnerships that are meaningful? And those are across, you know, public, private, social, multiple companies that sometimes compete, but now they need to work together. Youth, and folks in government or in power with influence. What are some of the practical lessons you've learned in trying to build the SDG platform over the last couple of months?
Thank you, Edwin, and thanks for those questions. I think in terms of engagement, if we look at Kenya, I think my own sense is that if you go north of the railway line, you're looking at probably about 70 to 90% of poverty indicators. If you go south of the railway line, it's much better to make an average of 45% people living below the poverty line in Kenya. So that shows to you that there is a great need to unlock areas that have been hitherto marginalized, left open, et cetera, but resources also. There's mineral resources, there's all kinds of other types of resources, livestock and the like, water, which haven't been tapped fully. So one of the approaches has been to look at broader area-based development opportunities. So for example, in Turkana, we have a joint UN flagship program with the government, where we're trying to create a much broader area-based development program that supports the county's county integrated development plan, that looks at unlocking a lot of the water resources. I mean, Turkana has underground water that can last 75 years, according to the county governor. And yet, we know that for 50 years, this has been one of the poorest counties. It's the only county that struck oil now, so all of a sudden, everyone's interested in Turkana. But the issue is, how do the youth, for example, and the indigenous communities get some kind of a dividend out of this unlocking of development in the northern areas. So when we look at approaches such as LAPSET and other infrastructure corridors, we know that the road has gone right up to Ethiopia now from Isiolo. How do we unlock opportunities for youth? And the opportunities for youth, I think I would put down to about 2 or 3 key things. One key area is, I think, skills development. Because we have in Kenya about 1 million job seekers every year that are added to the market. And yet, a significant percentage of these are unemployed or underemployed. And the issue is that we have this inverted triangle. Ordinarily, one would want for every engineer a few supervisors, many more foremen, and ultimately a huge number of artisans to support this triangle. In Kenya, we have the inverse. We have all these wonderful graduates that come out of universities with engineering degrees, but almost no artisans that are skilled and qualified, particularly in the hard-to-reach areas. So how do we get our youth to actually get these skills that are market-ready skills and that are quickly absorbed into the employment market by creating business incubation centers and skills training centers? And we're supporting counties. We've already launched 4 in Kwale, Tana River, Turkana, and Marsabit, where you take training to the youth. And given the livelihoods issues, you're actually able to take training from your conventional 40, 50 computer center in the middle of a county on a mobile platform to youth who are out there running bodas or running kiosks or tending goats, so they can actually get their training without losing their livelihoods. And you make sure that private sector is with you on the curriculum development with the government benchmarking to ensure that private sector is ultimately going to employ these youth. And I think this also allows for equity within the country, because we will otherwise find very skilled youth from urban centers taking over jobs where indigenous youth and some of these hard-to-reach places get left behind, which contradicts our whole clarion call with SDGs about leaving no one behind. We know where they're left behind, and so these are some of the strategies.
Fantastic. I'll come to you, Marc, on the specificity of what succeeded in the MDGs around HIV/AIDS initiatives, and the attack on the infectious diseases. We're seeing that the disease profile is beginning to change. Are there particular lessons we can take from there that would be worth keeping at the back of our minds as we're moving from, as we're trying to really get our hands around the SDGs from the previous MDG space?
Go ahead, Mike. Yes, sorry. So actually my question, I think I can paraphrase it, the one that I've been thinking about for the last couple of days. I don't work day to day with HIV, but CDC Kenya is a big PEPFAR partner. And so it got me thinking about, again, this issue that I brought up earlier about HIV being at least on paper, is specifically targeted at preventing people getting HIV and treating people with HIV and not getting AIDS. That's the 2 main objectives of the program. And yet I think that it clearly has got broader implications. And I think I was asked about, particularly about non-communicable diseases and other aspects of the SDGs and how that would help that. And so it got me thinking, HIV in effect is not like a normal infection. Normal infections, you want to cure them. HIV you don't cure, you manage. And of course that's what you do with chronic diseases. You manage them, you don't cure, rarely at least, chronic diseases. So there's a clear synergy there. And in my mind there are 3 buckets that HIV lessons from the MDG then can be moved on to the SDG goals and objectives. One is how the HIV programs, as they were scaled up, the behavioral and cultural aspect of prevention of HIV is very similar in the sense that HIV acquisition is largely behavioral choice. Many infectious diseases I can't avoid who I'm next to in a matatu. So you can get infections irrespective, and that's why we vaccinate against them, because it's difficult to do very effective behavioral interventions. But with HIV, it's a behavioral thing, very similar to hypertension and cholesterol and exercise, and all these are behavioral lifestyle choices. And I think the HIV programs have PEPFAR in particular, has worked very closely with communities to get lifestyle messages across to youth, going to the question earlier, and it's broadened, so it's not just about sexual practices, but it's about keeping girls in school, for instance, and making sure that they stay educated, and if they do that, then they won't be doing high-risk behavior. So there's a lot of messaging, I think, that has been perfected by HIV programs around behavior, around health choices, that I think is easily translatable to many of the objectives of SDG. This includes also SDG goals, for instance, maternal child health and neonatal mortality. A lot of the PMTCT activities are around preventing transmission from mothers to children of HIV, and that connects the mother to a child in a slightly different way, in a very specific health perspective, and empowers that woman to make choices to some extent about the health of her baby. And I think empowers women because they take their own drugs and it's to protect their child, and it's about preventing, also once the baby's born, you've got lactation, you've got risk, you've got a variety of different maternal child health issues that are related around HIV, that HIV has been addressing, that will support, I think, a lot of the maternal mortality and childhood mortality that we're seeing as part of SDG. So that briefly is one kind of bucket. I did want to put a plug in for a program called Search, where they combine HIV testing with things like blood pressure and height and obesity measurements. And they do these health fairs. This is an example of, they make it fun. They have all these activities. So they do HIV testing, but they also at the same time do a lot of the basic measurements that you need for chronic, for kind of healthy lifestyle activities. I don't know how much time I've got, but I've got two more. I've got 1 minute, okay. So I've got two more issues I wanted to touch on. One is clinical management of HIV programs. And clearly, if you're taking antiretroviral drugs on a regular basis, that's very similar to taking anti-cholesterol drugs on a regular basis. So the clinical management of HIV and the monitoring of HIV, for instance, for CD4 counts or for viral load, is very similar to what you might be doing as a diabetic. Yeah. So there's very similar issues there. There are complicated drug regimens that HIV programs have been able to educate and train relatively low-level primary health care providers to implement. And this comes back to strengthening primary health care systems, that now with HIV we can have people who aren't necessarily well-educated or well-trained or relatively lower level, I'm not sure if that's